The purpose of this part of the lecture is to look at the age-related considerations as we think about respiratory pathologies and pathophysiologies. So we're going to look at pulmonary disorders that are more common in children and talk a little bit about neonates. We'll describe the pathophysiology and some of the systemic effects of cystic fibrosis. And then we'll also take a look at some of the changes that occur in pulmonary physiology as we get older. So let's start by thinking about some of the normal physiology and why that becomes important when we think about pathophysiology in children. Now we know that children have smaller airways, and because of those smaller airways, when they become obstructed either because of mucosal surface edema or secretions, that then becomes more lethal and more problematic in their pulmonary system. The smaller the child, the more trouble they have with small airway obstructions. And so I think that's very important to remember. So part of this is about age, but the other part of it is about the size of the child and also the physiologic maturity of the child. So let's think a little bit about some normal physiology because, again, it makes sense when we think about pathophysiology. First off, remember that until about 3 months of age, the infant is a nose breather. Now, most of us, if we get a stuffy nose, what do? Well, we start breathing through our mouth. An infant below the age of about 3 months doesn't know to do that, and they don't do that. As a result, then, if they have a lot of nasal congestion, you're going to see respiratory compromise. We also know that the number of alveoli actually continues to increase during childhood until the child's about 8 years old. And then after that 7, 8, 9-year-old range, the alveoli continue to increase both in size as well as their complexity in terms of structure and function. With children, oxygen consumption is very high related to their body weight. And we think about that in terms of their high metabolic rate. So they have a lot of oxygen consumption, and it's more than we might expect in an adult or even an older child. So infants, young children, very high oxygen consumption. The last thing is this issue of surfactant again. Surfactant is absolutely key for infants that are born prior to 30 weeks gestation because surfactant, a lot of that surfactant production occurs in that 20 to 24 weeks of gestation and doesn't really become fully adequate until about 35 weeks gestation. If that surfactant is not present or if it's insufficient, this then leads to respiratory distress syndrome. And we've talked about the key role of surfactant previously, and remember, it facilitates expansion with inspiration, but also prevents the collapse of the alveoli at the end of expiration. So certainly these things that we've talked about in terms of some of these normal variants or these normal pieces about physiology and pathophysiology in a child is important when we think about pathology. So let's take a look then at some of the pulmonary disorders in children. We've previously talked about asthma, so I'm not going to go back over the pathology of asthma because the pathology of asthma in a child is the same as it is in an adult. It has both a reactive and, if it becomes chronic, can become an obstructive process. What's very interesting about asthma in a child is that children with eczema have an increased likelihood of demonstrating reactive airway disease. Now, the other thing that's interesting about this is when a child demonstrates asthma very early, remember this is in the small airways characterized by spasm as well as respiratory compromise, there's a question of whether or not a child may actually mature out of this asthma as their airways grow, develop, and their immune system matures. So that's one thing to think about when a very young child presents with eczema and then also then potentially presents with asthma as well. When we think about infections, again, they're prone to getting the same thing adults do, but there are two things that we want to especially think about with a child, and that is croup and acute epiglottitis. Now, croup can be either acute, which is a viral syndrome, or spasmodic, which has a questionable etiology. With an acute croup, as I said, frequently it is due to a virus, and one of the most common viruses is RSV, that respiratory syncytial virus that we talked about earlier. It may also be due to the influenza virus, so you want to have your antenna up during flu season. With acute croup, this is a laryngotracheal bronchitis, and it causes a lot of subepiglottal edema. Now, acute croup, and it presents frequently with a stridor with a very harsh sound on breathing. Acute croup is more likely in a child who is under the age of 3 years. So you're talking about young toddlers. The spasmodic croup, which occurs suddenly and has a questionable etiology, may or may not have a viral component, but this is the one that usually occurs at night. The child wakes up with a barking cough, with stridor, scares the devil out of their patients because their kid is in distress, they can't breathe. The child is scared because they can't breathe very well. But this usually happens in a child who's a little bit older than the acute croup. So it usually occurs in the older toddler, the early childhood age, right around the 3, 4, maybe even 5-year-old range. And of course, why are we worried about this? Remember, whether it's acute or spasmodic, it is characterized by subepiglottal pathology, and so you worry about respiratory compromise. Now, an acute epiglottitis is much less common than the 2 croups that we talked about. However, once again, this is something we want to watch for during the flu season, and we also want to watch for this in non-immunized children in those early childhood years, about 2, 3, up to 6 years of age. Acute epiglottitis, because it may be due either to the Haemophilus influenza, it may be due to influenza, strep, or staph, and this especially occurs under the age of a year. Very small airways, and it's characterized by severe inflammation, edema, and obstruction. And once again, that obstructive process frequently presents with stridor. And the child also tends to look ill because, remember, this has more of a viral or a bacterial connection. So let's turn our attention to some lower airway issues, and let's focus a little bit on neonates, especially looking at preterm infants. There are a couple of things that are especially important in neonates, and again, especially in preterm infants or low birth weight babies, and that's respiratory distress of the newborn, as well as bronchopulmonary dysplasia. With respiratory distress of the newborn, which we used to call hyaline membrane disease, but this RDS is something that we are concerned about because of the surfactant deficiency. Now, this may be either due to a decreased production, but it's also a decreased secretion. Remember that this surfactant comes from those type 2 pneumocytes. So when we see RDS, we know that we have a higher incidence in infants that are born prior to or right around 29 weeks. Remember, when surfactant starts being produced, it's right around that 30-week time frame. So 60% of children who are born at or prior to 29 weeks are at high risk to develop RDS, respiratory distress of the newborn, or respiratory distress syndrome. Now, what's important to also think about in this pathology, though, is the incidence of RDS has steadily decreased with the administration of surfactant to the infant immediately after birth, and or administering steroids to the mother during the pregnancy. Administering steroids to the mother during pregnancy actually helps increase lung maturation, and then that also then increases the baby's production of surfactant. I really should say the fetus's production of surfactant. So with RDS, what you see is increased resistance because of dysplasia that develops because of this of the deficiency of surfactant. So you have atelectasis and of the alveoli because of the collapse at the end of expiration. Because of the atelectasis, when the baby is born, they experience hypoxemia, hypercapnia, and develop a metabolic acidosis. Now, there's another thing that happens, though, in these preterm infants. If this child is preterm and develops RDS, circulation has a tendency to return to fetal circulation with left to right shunting. And that left to right shunting is going to occur through that ductus arteriosus as well as the foramen ovale. Now, because they've returned to fetal circulation with the left to right shunting, that worsens the pulmonary perfusion issues and then worsens the acidosis and the pressure on the pulmonary system. A second pathology that we'll see in very low birth weight infants, about 30% of very low birth weight infants, is bronchopulmonary dysplasia. As you can see, and as I note on the slide, it's associated with prematurity, but it's also associated with supplemental oxygen and ventilation using positive pressure, a lot of positive pressure in the ventilatory circuit. Because of what happens with this bronchopulmonary dysplasia is it either because of the O2, the prematurity, or the positive pressure ventilation therapy, it results in an obstructive, edematous, and fibrotic process. As a result, then, this can lead to a chronic obstructive lung pathology because of all of this resistance to airway. We also see in an infant a low birth weight infant who has been on a ventilator using positive pressure, it may also lead to pulmonary interstitial emphysema. And what happens in this pulmonary interstitial emphysema is that the alveoli and the bronchioles, which remember the very, 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 very small airways, actually rupture, and both oxygen and CO2 collect in the interstitium, causing fibrotic and obstructive symptoms and pathologies. Both bronchopulmonary dysplasia and this pulmonary interstitial edema can lead to a chronic obstructive lung pathology. With infections, very similar to adults, but remember those airways are smaller, they're more likely to be compromised, and the younger the child, the more immature their immune system is to fight against and overcome infections. So now let's talk about cystic fibrosis. When we think about cystic fibrosis, we tend to think about this as a disorder of children. However, cystic fibrosis, increasingly, kids that have cystic fibrosis are living into adulthood. The mean age right now of an individual with cystic fibrosis is in their 40s. And so thanks to our advances and our understanding of this disorder, children are surviving cystic fibrosis as kids, and they're growing up with cystic fibrosis. But what that leaves them with are chronic obstructive pulmonary disease as well as cardiac defects, and this is one of the populations that is a candidate for lung transplantation. So let's take a closer look at cystic fibrosis. This is an autosomal recessive genetic disorder. This gene is on chromosome 7, and it affects the CFTR protein. This is the cystic fibrosis transmembrane conductance receptor protein. The CFTR protein is responsible for chloride channels in the epithelial cells. These chloride channels, and therefore fluid transport, is the job of these channels. So what happens then is because they don't have this protein, they don't, and the chloride channels are poorly developed or don't develop, these receptors don't develop, fluid doesn't get transported into the secretions that the epithelial cells are responsible for. So you have that defective chloride ion transport, therefore fluid transport within the epithelium. As a result of this defective transport, you have abnormally thick secretions, and there are three main areas where this occurs: in the respiratory system, the digestive system, and in the reproductive tract. We're going to talk more about the respiratory effects, but let's talk about digestive and reproductive first. In the digestive tract, this primarily occurs in the pancreatic outlet, because the secretions coming out of that pancreatic outlet are very, very thick. It actually obstructs the pancreatic outlet. With that obstruction, then, it can also cause effects on the gallbladder. So what you'll see in these kids are very pale, non-fat containing stools. That's why their stools float when they go to the bathroom, because there's not a lot of fat in them. The other thing that can happen as a result of this is if you obstruct that pancreatic outlet, then it's more likely that this child would develop an associated diabetes because of the effect on the alpha as well as the beta cells. In the reproductive tract, these secretions clog and block the hormonal outlets and frequently leads to sterility. Now, as we said, cystic fibrosis is virtually always diagnosed as a child. And when we look at cystic fibrosis and we look at, although there are both respiratory and digestive and reproductive tract issues, respiratory and digestive tend to be dominant, with respiratory being highly problematic and the most difficult to treat. Cystic fibrosis is classed 1 through 6, and it's based on their mutations. The lower the number, the more severe the cystic fibrosis when they are classed 1 through 6. So let's take a closer look then at the respiratory effects. The respiratory effects of cystic fibrosis, regardless of whether this is a child or on into adulthood, is characterized by mucus plugging, chronic inflammation, and infection. So when we look at those mucus plugs, remember, this is all about chloride ion transport and therefore also fluid transport. But it's also due to increased goblet cells, both the number as well as the sizes of those goblet cells. Remember, goblet cells are the ones who produce mucus, and also an increase in submucosal glands. At the same time, because of this very thick mucus, lots of it, and very dehydrated mucus, there is decreased clearance of this mucus. That's what causes the mucus plugs. Those mucus plugs then facilitate inflammation and infection. Because of the chronic inflammation, there are abnormal levels of pro-inflammatory cytokines. There's a lot of IL-1, there's a lot of tumor necrosis factor, and there's actually lung damage, damage to the lung proteins elastin. Now remember, with this chronic inflammation, there's going to be excessive neutrophils as well as that neutrophil elastase. We talked about this neutrophil elastase before. Remember, that is the protease, and a protease then begins to damage the lung themselves. With the infectious process, this can be both chronic as well as endobronchial. The most when we think about infection in individuals with cystic fibrosis, they are virtually all colonized with Staphylococcus, and a very large number of them are also colonized with Pseudomonas, and then the Pseudomonas also becomes infection. So not only are they colonized, they also then become infected with Staph and Pseudomonas. Now, what's very, very interesting is, remember, Pseudomonas is one of those nasty, highly resistant bacteria. And it actually develops a resistant biofilm that is hard for an antibiotic then to get to. So let's think then a little bit about that obstructive process that's happening in cystic fibrosis. You have progressive bronchiectasis, which is persistent dilation of the bronchi, and the bronchi actually become bulbous. At the same time, those very small airways, remember, are clogging with mucus. As a result, what do they have? Yes, they have a ventilation-perfusion mismatch. So they are, shout at the screen, yes, they are perfusing but not ventilating. So they've got good perfusion. There's nothing wrong on the capillary side, but there's something wrong on their airway side. So they're ventilating, they're not ventilating, although they are perfusing. And that then leads to hypoxemia. As a result then, you're going to see a decrease in their minute ventilation, which is the amount of air they move in and out. And as we talked about, their PCO2 would also be elevated. Now, remember, this leads to a chronic obstructive lung disease. Therefore, the end result on the pulmonary system and the circulatory pulmonary system would be pulmonary artery hypertension And that can also then lead to cor pulmonale. So not only, although this is a primary pulmonary disease, think about the end result on the vascular system, because individuals with cystic fibrosis are at very high risk to develop pulmonary hypertension as well as cor pulmonale. So you can see why lung transplant is a therapy that can be very helpful. So let's go to the effects of aging. As we get older, there are some physiologic effects that then open an elder, especially as we get older and older, to pathophysiology. So some of those things that are going to be important include elastic recoil and the chest wall. In our airways, in our small airways especially, there is a decrease in the elastic recoil. Remember, expiration is a passive process, and when we exhale, we have to have that ability for our airways to bounce back and recoil and help us get that air out. That is, in addition to a decrease in the elastic recoil of the airways, especially the smaller airways, there is a stiffening of the chest wall. The ribs are less flexible. So as a result, then there's poorer compliance, there's less strength of the chest wall, and that then is going to lead to decreased endurance. So what that means then, if an elder develops a respiratory distress, an acute lung injury, or has a lung infection that is stressing their respiratory system to the max, their endurance to overcome that, to just keep up the work of breathing, would be diminished. We also know that there are changes in gas exchange. We know that as we get older, there is a decrease in our alveolar surface area because of decrease in alveolar wall tissue, as well as a decrease in our capillaries. This then decreases our total surface area for gas exchange as we get older and older. Now, what's very interesting then is what that means is our arterial PO2 actually decreases with age, and then there's a little formula for that. Now, what's important here, though, and this is critical, is that even though that PaO2 decreases with age, the PaCO2 and the pH do not change. And that's important, because when you look at blood gases, you don't want to think that the PaCO2 or the pH should be different because someone is older. We also know that as we get older, because of that stiffening of the chest wall and the decrease in the elastic recoil, there is more resistance in our airways. So the end result of these effects of aging is decrease in ventilation. We see an increase in our residual volume. We may see a decrease in our vital capacity, but the total capacity does not change. Remember, total capacity is the vital capacity as well as the residual volumes in our lungs. We do, however, because of those changes that we talked about, have a decrease in the ventilation-perfusion ratio. Now, even though with all of this, however, we want to remember that shortness of breath is not a normal variant of aging. Even though there are changes in the pulmonary system, shortness of breath is not normal. And I think that's something that we have to help elders understand as well. We would always look at dyspnea or shortness of breath and go looking for what's causing that, because it's not a normal variant of aging. As we put all of this together, then, we also want to remember that there is an increased risk of infection as we get older because of difficulty in clearing our airway, as well as some changes in our inflammatory response as we get older. We still mount an inflammatory response, but it may be slower and less effective. So if you put that together along with some of the other things that we've talked about in other body systems, then what about individuals who have multiple chronic illnesses, who also have heart failure? Overlay that with the anemia of chronic illness, and you can see that respiratory compromise may occur more rapidly in an elder than it may in a middle-aged or a younger individual. So in this whole piece that we've been talking about, not only in this last piece with the aging considerations, but all the way through the pulmonary system, we know that respiratory disorders include both the upper as well as the lower airways, even though we've talked more about the lung parenchyma itself. The effects of ventilation and oxygenation are absolutely key, and it's important that you be able to differentiate whether the VQ mismatch, that ventilation perfusion mismatch, is on the ventilation side or on the perfusion side. We talked a lot about how we frequently can sort of classify diseases as restrictive, obstructive, and even infectious. Children are at risk at earlier ages because of those very, very small airways. Those small airways are more likely to be compromised. And once again, as we age, we change. Thank you for your attention. Please let me know if you have questions.